thank you very much for inviting me to give this oration today. So I'm just going to share my slides now, and hopefully everyone can see those slides. So I've been asked to talk about the diagnosis and management of LADA, which stands for latent autoimmune diabetes of adulthood. And it is a naughty topic, actually. As you'll see, there's a lot of controversy in this topic. So I'm going to go through the definitions of LADA, which, as you will see, are quite controversial, how we recognize cases of LADA, and also touch on the management of LADA. So I always think it's useful to start off with a case, and this is somebody I saw reasonably recently. They were 65, they'd had their HbA1c checked because of tiredness, they were lean with a body mass index of 20 and had a history of Hashimoto's thyroiditis. And they were seen by their family doctor, diagnosed or essentially labeled with type 2 diabetes, advised to lose weight and started on metformin. And this seemed to be quite an effective strategy. So within a year, this person had an HbA1c of 5.5%, which is in the non-diabetic range. And they'd also lost a bit of weight. So their body mass index had reduced to 18. Now, this person came to me approximately 2 years after their diagnosis. And at this point, the HbA1c had crept up quite significantly from that nadir of 5.5 to 8%. They were still just on metformin. They were struggling to maintain their weight. They had an HbA1c of 8% despite following a restrictive low carbohydrate diet. And a number of possibilities as to the underlying diagnosis went through my head. Of course, I decided to measure pancreatic autoantibodies, and her GAD65 antibody was positive. And she told me that she was scared to even eat or look at carbohydrates. So she'd ended up mentally in quite a fragile state from this diagnosis. And I'd like you all to think about what you would do in this particular case. And I'm going to come back to it at the end. And possibly some of you will disagree with what I did, but we can hopefully discuss that. Now, one of the first things to get straight in our minds is what we mean by LADA. Now, I've listed 3 things here: late onset type 1 diabetes, LADA, and adult onset type 1 diabetes. And I have to be honest, although I'm giving the talk about LADA, for me, the clinical entity of LADA is essentially a later onset presentation of type 1 diabetes. And we know from immunological and genetic studies that the later you present with type 1 diabetes, the more gradual the onset and the less likely you are to crash land with complete beta cell failure. And so what we're really saying when we talk about LADA is we're saying that someone in adulthood has got type 1 diabetes, but it's not the aggressive condition that we see in children diagnosed with type 1 diabetes, who very quickly progress to no insulin production. And you hopefully will have seen a graph like this or similar. This graph is taken from a lovely review of type 1 diabetes in the Lancet a couple of years ago. But it's actually, the first publication of this graph was by Eisenbarth many decades ago. And it shows the stages of the development of type 1 diabetes, with age on the x-axis and the amount of C-peptide that is made by the pancreas on the y-axis. So you start off with being genetically predisposed, but having normal beta cell function. And then following a precipitating event, there is a gradual decline in beta cell function, with eventually the presentation of overt hyperglycemia. And we tend to say that this occurs once 80% of the beta cell function is lost. And eventually this will progress to complete loss of beta cell function, i.e. complete loss of insulin production, at which point the person will be at risk of diabetic ketoacidosis. Now, I've created my own version of that chart. And the way that I think about LADA, if this blue line here, T1DM, represents what we just saw in the previous graph from the Eisenbarth model, then LADA perhaps looks a bit like this. So it, the 100% beta cell function until later on in life, I mean, we start to lose beta cell function from the age of 20, but, just to simplify things. And then we've got a gradual decline towards diabetes around about here. And perhaps this line never actually touches zero. Perhaps this line just carries on slightly straight. And there is some consensus about what LADA is. So generally speaking, it's diagnosed over the age of 30. Some people say 35. There's the presence of a pancreatic autoantibody, most commonly GAD65, and at least 6 months of not requiring insulin treatment. So again, this is not somebody who's crash landing with osmotic symptoms and diabetic ketoacidosis. This is someone that has a very gentle and gradual progression into diabetes. And what we don't know is whether this as an entity is separate to this green line, which I've now superimposed on my cartoon here, which is the same type 1 diabetes of childhood, but just presenting later on. Perhaps this is also possible. I know I see people like this myself, people in their 20s, 30s, 40s who crash land with significant hyperglycemia, osmotic symptoms, catabolic, potential DKA. So is LADA a separate entity to adult onset type 1 diabetes? And as was alluded to in my introduction, there is some suggestion that genetically and immunologically, there is a distinction between adult onset type 1 diabetes and LADA. And one of the reasons why we haven't managed to sort this issue out is because a lot of the studies looking at LADA have defined LADA very differently. So this is taken, if you're interested in LADA, I'd urge you to read this consensus statement from Buzetti and David Leslie. It published in Diabetes last year, and it basically summarizes the features of LADA. So there's the age, the later age, a history of autoimmunity, potentially some features of metabolic syndrome, C-peptide levels that decrease more slowly than in type 1 diabetes, positivity to GAD antibodies, and again, not requiring insulin at diagnosis, as we've just said. So moving on to classification. Now, I'm going to show you 3 very simple case histories. So we've got a 24-year-old who's feeling tired and thirsty, so osmotic, body mass index of 26, so slightly overweight, random glucose of 22. Now, hopefully all of you that are listening to my talk have got an idea in your head about what type of diabetes that this person has. And in England and London, where I am right now, we would probably unequivocally think of this person as having type 1 diabetes, because that is more common in younger age groups over here. And perhaps in somewhere like India, where we know that type 2 diabetes presents earlier, you might be thinking that this could also be type 2 diabetes. If I change the body mass index of this person, but give them the same symptoms and the same random glucose level, your index of suspicion will have shifted, rightly so, to type 2 diabetes. And if I keep the BMI as just modestly overweight, but increase the age of the person, then again, you might have shifted from type 1 diabetes to type 2, or perhaps you think all 3 of them have got type 2 diabetes. Now, if we add ethnicity into the mix, and I've picked 3 ethnic groups here, so South Asian, African Caribbean, and Middle Eastern, these are ethnic groups that we know have a preponderance to type 2 diabetes. And so you might have shifted even more your index of suspicion towards type 2 over type 1. And so what we've just been through, I hope you were thinking through this with me, is that we've used patient factors as modifiers of the likelihood of someone having type 1 diabetes. We've used age, we've used body mass index, and we've also used ethnicity. But how reasonable is it for us to use age as a modifier of our index of suspicion? Well, some of you may have seen this study from Lancet Diabetes and Endocrinology about 3 years ago now, where the Exeter team, who are collaborators of mine, used genetic risk, so polygenic scores, to define type 1 diabetes in UK Biobank. UK Biobank is a big collection basically of a population study of about 500,000 people. And what this graph shows is if you plot people who've got diabetes in UK Biobank and split them by whether or not they have a high genetic risk for type 1 diabetes, which is this maroon color, what you can see is that at every decade of age at diagnosis, there are people with a very high genetic risk of type 1 diabetes. And so this is some of the most robust evidence that we have in a white Caucasian population that type 1 diabetes can present throughout life. And certainly my clinical practice would agree with that. We've also got a study that my team runs from Imperial called the Address 2 study, which recruits people around England that have a diagnosis of type 1 diabetes, and we systematically check autoantibodies in these individuals. And what you can see is that 40% of the individuals who were labeled as type 1 diabetes were actually overweight or obese, and that's probably maybe astonishing when you first hear it, but not astonishing to me, because if at a population level we're getting fatter, then of course there's no reason why somebody who doesn't meet the criteria for obesity can't develop an autoimmune condition. Now, of course, the caveat to this and why it's so tricky to make a diagnosis of LADA or later onset type 1 in Asian people is the fact that South Asian people, and this is a study from the Lancet about 5 years ago now, have developed diabetes, as we know, at a lower BMI than white Caucasian individuals. And so it becomes quite challenging to pick out the type 1 cases from this group. So just to put some figures on this, in the Address 2 study, 1 in 10 people recruited with type 1 had been diagnosed over the age of 40. And in the UK Biobank study, actually 40% of all type 1 diabetes was diagnosed over the age of 30. So the point of these few slides is to say that this is not a rare diagnosis. These cases are out there, but we're struggling potentially to recognize them. And the problem is occurring, I've put this cartoon together, the problem is occurring because we classically think of type 2 diabetes as occurring at later age and at higher body mass index, and type 1 diabetes essentially being a diagnosis of childhood. But actually, as I've shown you, type 1 diabetes can occur throughout adulthood, and type 2 diabetes in Asian populations particularly occurs at younger age and at lower BMI. And it's sort of the overlapping teardrop effect. And so the challenge in the South Asian population is to differentiate those later onset cases from the haystack of early onset type 2 diabetes in relatively lean BMI individuals. So what are some things that have helped me? And I'd love to hear from everyone at the end of my talk as to how they identify LADA. But given that BMI and age are not very good discriminators, the things that I look out for the recognition of autoimmune diabetes in adulthood, and we can debate whether that's LADA or type 1, is a transition to insulin quite quickly after diagnosis. So if we've got a very straightforward type 2, they should not be going on to insulin within a few months or years of diagnosis. Relatively lean, but as we've said, overweight does not exclude. One of the things that I find particularly helpful is an absence of a family history of diabetes. So in ethnic groups that have overrepresentation of type 2, one or both parents is very likely to be affected with type 2 diabetes. And if you see neither parent has diabetes, that really does, for me, potentially point to an autoimmune diagnosis. And of course, having a history of another autoimmune condition can be helpful. We also use biomarkers. We've talked about some of them already. So I will frequently undertake in people that I think have LADA or late onset type 1, GAD65, IA2 and ZMT8 antibodies, which are the ones that I have available to me. C-peptide levels are actually less useful at diagnosis. When people come in acutely, they can have stunning of their beta cell function due to glucotoxicity and lipotoxicity, and there can be recovery of C-peptide. If you measure C-peptide a few years after diagnosis, you get a better picture of whether or not someone is completely insulin deficient or not. And the other thing that I find useful is to actually do something straightforward like a lipid profile. If I think someone has got type 2 diabetes, they should have a classical dyslipidemia of insulin resistance, whereas we often find people with autoimmune diabetes actually have relatively high HDLs. Now, of course, this becomes problematic if you are South Asian with potential concomitant insulin resistance. So this is not, a fantastic discriminator, but it's a piece of evidence that helps build up a picture. So finally, just on to management. Now, the management of LADA compared to type 2 diabetes and type 1 diabetes is comparatively an evidence-free zone. And if you want to update yourself on the latest, I would again read this consensus statement published in Diabetes last year. And if you go through it, most of the evidence is low or moderate. So we are really in need of good quality studies in this area. And there is a huge controversy amongst clinicians. In fact, the case that I described to you at the beginning, I discussed in our multidisciplinary team meeting at Imperial, which I chair, and nobody agreed with each other. So people are split between, it doesn't matter, it's an autoimmune condition, we should treat it like type 1 diabetes, and the other half are willing to explore the use of alternative therapies. So in preparing these slides, I was trying to come up with the process that I go through in my mind, and I came up with this acronym DIME. It's not published or anything, it's just how I think about things. So the first thing, D, is to decide whether the person in front of you has Barn or type 1 diabetes that's presenting in adulthood, or whether you think there are features suggestive of LADA, i.e. a more gradual presentation. The I stands for individualize. So obviously, if we think someone has got type 1 diabetes, we should treat them with basal bolus insulin, offer them structured education, discuss technology, etc. And it's those where there is what I describe as gray cases where those additional options may be explored. The M and the E are the most important parts of the process. M is monitoring. So whatever we do, we need to hang on to these individuals. Even if we've got them on orals, we need to hang on to them, follow them up, and if necessary, repeat C-peptides when we're not discharging these people who are on orals. And finally, education. These people need to know that they don't have type 2 diabetes. This is a autoimmune condition with a high risk of progression to beta cell failure. So let's just go through these in the last few slides. So I want to labor the point here because I think this gets lost. Adult onset autoimmune diabetes can be straightforward type 1. They can present osmotically with weight loss, with infection, be catabolic with or without DKA. And I've got a picture of a dog there because we've got a phrase over here. If it walks like a dog and it looks like a dog and it barks like a dog, it's a dog. So never fall foul of this idea that type 1 diabetes cannot present in a 50 or 60-year-old. And if it looks like type 1 diabetes, we must treat them with insulin. If we've got the other scenario where the antibody is positive, but now we've got someone with a more insidious presentation, perhaps it's an incidental finding, they're not osmotic, they're in that gradual category. Well, like I said, some doctors would still put this person on insulin and give them the full type 1 education, but others would consider other treatments. So should LADA just be treated like type 1 diabetes? Well, we went through this in my MDT meeting just a couple of weeks ago, and I've listed some of the reasons in favor of doing that. So we know that insulin is very effective at reducing HbA1c. In these individuals with LADA, where I showed you with the gradual decline, we don't know if they might suddenly decline down to 0 beta cell function and be at risk of DKA. If we have them on insulin, we can advise them what to do on sick days. If they develop coronavirus or flu, they simply need to up titrate their insulin. It's safer to provide specific education at diagnosis rather than ending up in this situation where you say, oh, you don't need insulin right now, but you might need it later, and that the patient becomes very reluctant. And worth saying that there's no compelling evidence that any oral agents preserve beta cell function. Why shouldn't we just put these people on insulin? Well, as you know, lots of people don't like being on insulin, and the burden of insulin treatment should not be underestimated. There is a risk of hypoglycemia. It affects employment. It affects quality of life. We also probably all have patients, I know I do, where they've actually retained significant C-peptide and been on orals for over a decade, despite having a positive GAD antibody. And if that were the case, would you want that person to be on basal bolus for 10 years when they could have just been on metformin and sitagliptin? Of course, the other reason now in the last few years is we know that there are oral agents that have proven CVD benefit in secondary prevention, which insulin would not provide. So those are some of the discussions that we have in these cases. Now, the consensus statement that I've alluded to has come up with a nice algorithm to assist us, and it's based on C-peptide. And I have a bit of a problem with this because C-peptide cutoffs are not validated in all ethnic groups. And people with C-peptides above 0.3, this is nanomoles per liter. I use picomoles per liter, so that would be between 300 and 700 picomoles per liter. To say that that person doesn't need insulin, I think is unsafe. So we always have to look at someone in front of you. I've got patients who come in DKA with C-peptides of 800. So if someone says to me, oh, they don't need insulin, that's negligent. So these hard and fast C-peptide cutoffs, I don't think we should be following them to the letter, but we should be using them as a guide. What they say is that if C-peptide is below 300, you absolutely need insulin. When it's in this gray zone between 300 and 700, if someone has got a history of cardiovascular disease, you can basically follow the EASD ADA joint guidelines, try GLP-1, try SGLT2 inhibitors. In people without established CKD or atherosclerotic cardiovascular disease, essentially the mantra is you can try an oral such as DPP-4 or SGLT2 or thiazolidinedione or even a GLP-1, but if you're not reaching your target, then the next option is pretty much insulin. So I view it as there's a possibility that someone might respond to one of these adjuncts, but there's a very low threshold to transitioning them to basal insulin. And SGLT2 inhibitors in particular make me a little bit nervous in this group of individuals. As we know, there's an increased risk of euglycemic ketoacidosis with SGLT2 inhibitors. And I certainly have never used SGLT2 inhibitors in people that I think have autoimmune diabetes who are not on insulin. So I'm not a particular fan of that suggestion for SGLT2s. Finally, the M and the E of DIME. So monitoring is important. Like I said, we shouldn't be discharging these individuals, and education is really important. These people are usually surrounded in their age group by people who've got type 2 diabetes. So it's very important to highlight that they don't have type 2, they've got autoimmune disease, and go through simple things like sick day rules and recognition of when they might need insulin. So finally, just to go back to KP, you probably all had your thoughts about what you would do. And what I did was I put this person on basal bolus insulin. And the reason that I did that, I can't actually remember what the C-peptide was. I was trying to remember this morning. The reason that I did that is that this person, despite following a highly restricted carbohydrate diet, I think at one point they were taking about 50 grams of carbohydrate a day, their HbA1c continued to rise. And they were anxious and stressed about being unable to eat and calorie intake. And the only thing, in my opinion, in somebody with a BMI of 18 and a history of an autoimmune condition, the only thing that is going to address that and reestablish the quality of life that this person needs is actually insulin. So I put this person on basal bolus insulin, and we can debate if you disagree with that. So in summary, LADA is an adult presentation of autoimmune diabetes with a slow progression to complete beta cell failure, if at all. It classically has hybrid features between type 1 and type 2 diabetes. I think that's a bit irrelevant because the whole population is getting fatter. It can be treated with orals plus insulin or insulin. Adult onset type 1 diabetes is used interchangeably with LADA, but I think it's really important to make sure that we clearly segregate in our minds a very straightforward barn door type 1 diabetes case from these hybrid cases. And of course, the treatment is insulin. And I want to end by saying, is the distinction academic? Because whatever we do is individualized to the patient in front of us. So I literally never use the diagnosis of LADA. I just call it late onset type 1 diabetes, but I look forward to debating that. Thank you very much for the invitation, and I hope there are some questions.